All right, I have 1 o'clock here, so I think we're going to get started. I'd like to welcome everyone to this month's Science for Non-Scientists presentation. For those of you who don't know me, I'm Dr. Mary Pfeiffer. I'm with the IRP's Office of Education and Career Development. And I'm very pleased to have Dr. Jean-Luc Cadet as our speaker today. But we're doing something a little different today. We're having, this meeting is held jointly with the NIDA's REI, or Racial Equity Initiative. And I'd like to introduce Dr. Emily Einstein, who is representing REI today. I have to put my reading glasses on here. Dr. Einstein is in the Science Policy Branch of the Office of Science Policy and Communication. She started there in 2015, and she primarily develops materials to communicate the science of addictive drugs and substance use disorders, with an emphasis on prescription opioids and heroin. And she's also one of the leaders of the REI group. So Emily, take it away, please. Thank you. Emily, did you hear me? I'm sorry, did everyone hear that? I'm getting a lot of feedback, so I couldn't tell. Did you hear the introduction?
Dr. Cadet, you're on mute.
I muted Dr. Cadet for a moment temporarily. I think the feedback is going through his speakers back into his microphone. So I can.
Okay, did you hear me? Did you hear my introduction? I'm sorry.
I did, but it was feedbacky.
Yeah, I think because of the Cadet thing. So Emily, if you want to go ahead, you can take it away.
So sorry about that. My network just cut out. But
that's all right.
Gaia Dowling is my co-lead for the Racial Equity Initiative, and we're both delighted to co-present this lecture today. Am I unmuted? So the Racial Equity Initiative has 3 groups composed of volunteers from both IRP and HQ. The first is a group concerned with racial equity in the NIDA workplace. The second is racial equity among NIDA's research workforce. And the third is issues of racial equity in research gaps and opportunities in NIDA's research portfolio. So we invite you to join us on February 10th, when we will be having a NIDA-wide update on the activities of these 3 groups, which include a NIDA-wide climate survey, a portfolio analysis, and the establishment of an internship opportunity between UMBC and NIDA IRP. We also invite you to join us on February 16th and 17th, when we will be having a scientific meeting around research gaps and opportunities related to racial equity and addiction science. So now it's my pleasure to introduce Dr. Jean-Luc Cadet. He is a tenured senior investigator and chief of the Molecular Neuropsychiatry Research Branch and chief of the Molecular Neuropsychiatry Section at NIDA IRP. Dr. Cadet attended Columbia University College of Physicians and Surgeons and obtained his MD in 1979. He received residency training in psychiatry at Columbia University and in neurology at Mount Sinai Medical Center. Dr. Cadet came to NIDA IRP in 1992, and he has co-authored more than 300 papers, abstracts, and book chapters on the mechanisms of addiction in the brain and on cognitive dysfunctions observed in people with cocaine and marijuana use disorders. Presently, his laboratory is studying how stimulants and oxycodone can cause epigenetic, transcriptional, and biochemical changes in the brain. I'll turn it over to you, Dr. Cadet. Very much looking forward to your talk.
Thank you very much. Thank you, Mary Pfeiffer. Thank you, Emily Einstein, for inviting me to talk about these topics that should be of interest to all of us. Even though more racial disparity in health have been ravaging the Black community, it took the summer of 2020 with the virtual murder of Mr. Floyd and the COVID epidemic to get the increased morbidity and mortality associated with these diseases to be televised. So this afternoon, what I'm going to try to do is go over several subtopics, starting with the political and economic forces that drive racial inequity in the United States. I will list examples of racial inequity in medicine, including experiments performed without informed consent. I also will discuss the racial inequity in medical staffing and in NIH grant reviews and awards. And these days, you have to talk about the racial inequity in the clinical course of COVID-19. And finally, I'll talk briefly about racial inequity in substance abuse disorder research and the lack of Black representation and community involvement in such research. Before we go forward, I would like to mention some definitions that are very important for people to keep in mind. Health equity is the opportunity for everyone to attain their best health potential. Health inequities are differences in health that are secondary to economic, environmental, and/or social disadvantages. And health disparities that result from those are differences in health and disease outcomes between ethnic and racial populations. First, let's talk about the political and economic forces that drive racial inequities. This has been going on for a very long time in the United States, and it began in 1619 when the first enslaved Africans landed in the British colonies. Even after the Civil War, there were continuous segregation with laws passed to maintain this segregated states. After 1954, there was still segregation, and I will show you a map later on of Baltimore, where a city that is still very segregated. Now, so how did we get to where we are today? After the Civil War, there were several occasions where laws were passed to maintain African Americans in areas where that were basically not livable. One of them is the mortgage redlining. In 1935, we have the Homeowners Loan Corporation, where African Americans could get loans depending on where they lived to buy new houses. So they were basically restricted in those areas. And then in 1944, after the war, the GI Bill didn't benefit Black veterans because they didn't have access to those loans, while white families, white GI, benefited from these loans that moved them up to middle class or upper middle class. So therefore, these discriminatory practices were the driving and are the driving forces for the social determinants of health, so that social, as you can see on the slide, socioeconomic factors represent 40%, physical environment 10%, health behaviors, which are very important for all of us, represent about 30%, and then access to health care. As you all know, all of these have impacted the lives of African American, Black Americans very negatively. For those of you who are interested in that aspect of healthcare, this book, The Color of Law, really goes into a lot of the laws that were passed to maintain Black Americans at the bottom of the wells. Now we'll talk about racial inequity in medicine. In medical school, the first thing that we learned was primum non nocere, first do no harm. But as I went to medical school at Columbia and talked to some Black physicians who were working at Harlem Hospital, I learned very quickly that white physicians, including those from my alma mater, were behaving more like white colonialists or great white saviors. And when they approached Harlem Hospital to do their research, they behaved more like white supremacists than physicians. A lot of those issues are covered in these 4 books that I try to get people to read. One is Medical Apartheid by Elliot Washington, The Political Determinant of Health by Daniel Dawes, Killing the Black Bodies by Dorothy Roberts, and Medical Bondage by Deirdre Cooper Owens. Those books are really important books. I think everybody, whether PhD or MD, who are interested in doing research with Black participants should read before they engage those populations. What we've seen in the United States, and people refuse to talk about and claim that those happened back in the days, but we need to know the truth about what happens in American medicine, especially when it comes to the fact that now people are complaining that Black Americans are not willing to take the anti-COVID-19 vaccine. There's a history beyond those behaviors. There was the eugenic agenda, where many Black women were sterilized without their knowledge. And I will talk briefly about the experimentation that were done on enslaved Black women. And the Tuskegee syphilis experiment is one that families are still suffering from, even though the experiment was stopped in 1972. And then the story from John Hopkins of Henrietta Lacks, whose cancer cells were stolen without her consent. So about the Dr. Sims was, except now that a lot of his statues have been taken down and he's not being looked at in the same way that he was looked at in OBGYN circle, because he did experiments on Black women without giving them anesthesia, because he believed that Black people responded to pain differently from the way white people respond to pain. So he practiced a lot of his surgical, he became a very skilled surgeon, I should admit, but he did so by practicing all of his surgical skills on Black slaves before, when he got good at them, then he would use them in white women. So Dr. Sim is somebody that we need to keep in mind when we're talking about racial disparity in health and or medicine. what happens with Henrietta Lacks, I think most people probably know about this now. She was a young mother of 5 children who presented to Johns Hopkins Hospital with vaginal bleeding. Upon examination, Dr. Howard Jones discovered a large cervical tumor. She was treated with radium therapy. Dr. Gay was a virus cancer researcher who was collecting cells from patients at Hopkins without their knowing. And most of the cells that he's collected prior to Henrietta Lacks cells would not divide in culture. And what he discovered was her cell continued to double every 20 to 24 hours. So he's published quite a few papers using these cells, and these cells have been used to study toxicity, genetic studies, and in some of Dr. Gay's papers, he talked about the development of the polio vaccine. The Tuskegee experiment is also notorious. That study lasted from 1932 to 1972. That's 40 years, where some physicians, white physicians, were not treating Black men who were suffering from syphilis. Now, people talk about the fact that the Black male were not being treated, but these men were going home and interacting with their wives who were birthing children from these men. And so the families suffered significantly. It was just the Black male. So there was a report about the Tuskegee syphilis study, but that report, if you read it, it's a complete whitewash of what really happened in that study. And then on the same, around those years earlier, one of the problems with the American Medical Association was that they refused to let Black physicians enter in their ranks. So Black physicians back in 95, decided to form their own organization, the National Medical Association, of which I'm a member. NMA is still going on. Now, let's talk about racial inequities in medical staffing. This is more relevant for us as a NIH institute. So why do we need racial equity in science and medicine? And there are lots of papers that have shown that teams that have members of different groups, okay, think about problems differently and usually come up with more creative ways of dealing with scientific questions. Same with people from various racial backgrounds and life experiences bring different perspectives to address scientific problems. This diversity also helps to balance and broaden perspectives in terms of setting research priorities. And finally, I'm sure people can come up with some other reasons, the presence of scientists and of physicians from different groups would increase the likelihood that issues that affect underserved population are discussed. So we all know this. The people at NIH know this. But when you look at the demographic data in terms of scientists at the NIH, so this is a table that a friend of mine, Charles Ogwagu, who's an investigator, tenured investigator at NEI, put together. So if you look at the years, in 1994, there were 7 tenured African-American scientists at the alternate track investigators at the NIH. In 2004, we had 5. In terms of tenured investigator, there were 8 in 1994, and in 2004, there were only 10. So in 10 years, NIH only tenured 2 African-American scientists. But the interesting thing, around the same time, the NIH was able to hire a number of Black PhD administrators, moving in 1990 from 38 to 91 in 2000. So what we decided, the tenured investigators at the NIH, we concluded that the problem of attracting qualified investigators is not a pipeline issue, because the NIH was able to hire PhD administrators, so that NIH seems to be better at recruiting Black administrators than they are at recruiting Black scientists. The question is, why is that? In 2020, the number of Black investigators went up to about 13, so that from 2004, 16 years later, the NIH was only able to increase their numbers by 3. That's pretty disgusting, if you ask me. So that the percentage of Black scientists at the NIH is only 1.2%. And you should remember that now African Americans occupy 13% of the general American population. So those are facts. Those are not things that are made up. That's straight out of the NIH coffers. Now, if you move out of the NIH and you look at medical institutions, mostly medical school around the country, the underrepresentation is still there. They actually do a little bit better than the NIH. So they're about 2.7% of PhDs and MDs on the staff of medical school. But in terms of active physicians, we have about 6% of physicians around the country are Black physicians. Now, those numbers, I should tell you, have not changed since the time that I attended medical school in the 70s. Even though every decade after 1970s, when people started to talk about, wow, there's a shortage of Black physicians, you have all this white medical school, or should say medical school attended majority white, they say, okay, we're going to improve. But over the past 40, 50 years, there hasn't been any improvement. This issue of racial inequity in awards of NIH grants is one that is very bothersome. So in this paper published in 2011, the authors concluded that NIH training, experience, holding previous grant, the number of publication or citation did not translate into the same probability of grant success for African-American applicants when those applicants were compared to white applicants. Follow-up study published in 2019, where the investigators look at awards from 2011 to 2015. They reviewed a lot of new and renewal applications and found that only 10% of the awards were for African American scientists, while 17.7% were awarded to white applicants. Black scientists, they concluded, were less likely to resubmit grant application than white scientists for 2011 to 2015. And in the paper, I took that figure from the paper. The authors reported that there were racial gaps at each level of the review of the grants. So, and then we ended up, as I mentioned before, with Black investigators obtaining many less awards than white applicants. So one of the important aspects of that study was that they found that African American scientists tended to submit more human studies than white scientists. They also mentioned that the grants from African American scientists fell into 8 clusters, and six out of the 8 clusters had award rates that were way below NIH average. The authors discuss the possibility that, or the fact that topics focusing on disease prevention and intervention were less likely to be funded. So just to compare the study from 2011 to 2019, as you can see here, the gap, the success rate of African Americans was 0.58, while the success rate for African American in 2019 was 0.60. So there were no significant improvement over a 10-year period, that's very troublesome also. So the one problem I had with this paper was that the authors, instead of discussing racial disparity and racial inequities, they started to talk about implicit bias. I think from my perspective, discussion of implicit bias is a non sequitur. We should name racism when we see it, otherwise no improvement is going to happen in science and medicine. So I wish in that paper they discuss issues related to racism. They could have talked about institutional racism, the structural racism, internalized racism of the reviewers, and not so much interpersonal racism, because most of these investigators don't know Black scientists. Questions. So how do we go about fixing this gap that exists at all levels of the review process? How do we change the minds of reviewers who assign low priority scores to studies that focus on prevention and racial disparities in healthcare? Would implicit bias training of those reviewers change the way they approach their review of science? I don't think that's really the case. We need to address this much more aggressively if we want to see differences. Let's talk about COVID-19. We have to talk about COVID-19 because this is really impacting the Black community in a very bad way. What we have said before, there are racial disparities in maternal death rates, infant mortality rates, hypertension, diabetes, other diseases. But now what's in the mind of everybody is COVID-19. So what this slide shows is that the prevalence or incidence of COVID-19 diagnosis seem to occur at a much higher rate in zip codes where Black Americans live. There are papers describing the predictors of in-hospital death in New York, and Black Americans were dying at a much higher rate. This was true of patients in Detroit, also true in patients in Louisiana. The study from Louisiana is very interesting in terms of their discussion because I think they did a better job than the other two papers that I mentioned. They had 76.9 of the patients needing hospitalization for COVID-19 were African Americans, and 80% of those requiring mechanical ventilation were also African Americans. When they look at Black race, obesity, increased age, and residents in a lower income area zip code, right? Remember that these residences were set up by legal means so that Black Americans end up living in these areas. So those were associated with increased risk of being hospitalized for hypoxic respiratory failure and pneumonia. So they did something that was also very nice. They control for race and some other diseases. And what they concluded was that increasing age, high respiratory rates upon admission, high creatinine and lactate level, low platelet counts, but not being African American independently were associated with increased mortality. That tells you that racial disparity, because of what I've described before, were really responsible for the increased mortality. So I took all of these papers together, what I concluded was that testing was very important, existing medical problems, provider biases. You could see that some people were being turned back when they came to hospitals, ended up dying at home because of COVID. Potential exposures on the job. I remember, I used to live in New York, and at the beginning of the quarantine, you could see that there were all these Black Americans in subways coming from work, while people like me and you were hiding in our houses. Structural racism that ignores the plight of those at the bottom of the wells has contributed to the increased mortality of COVID-19. Now let's talk about racial inequity in substance use disorders. Among Black Americans, young adulthood is a period of initiation of drug use. Okay, discrimination influences the prevalence of problematic drug use and the development of diagnosis of substance use disorder. Black pregnant women are less likely to receive treatment against opioid use disorder than white women. Despite lower rates of opioid use disorder, overdosages among Black Americans are now outpacing those among white individuals, okay? So there are racial inequity in substance use disorders that we need to talk about. So what are the potential causes for this racial inequity in SUD prevalence and complications? So this, I stole it from this paper. So we have these things going on. We have poverty, poor access to care. This one is the big one for me. Poor nutrition, because people live in food desert. Smoking is still highly prevalent in some African American community. The stress of daily living as a Black person in the United States, and racism. I've coined this term called racism-induced stress disorder. It's pervasive, it's existent. People try to deny it, but it causes a number of psychiatric diseases such as depression and anxiety and physical abnormalities like diabetes mellitus, hypertension, and increased prevalence of stroke and decreased lifespan. So this is very, racism affects the lives of Black men and women in every possible situation. The one that's probably the worst one is the criminalization of young Black people who are using small amount of marijuana or other drugs. At the time of the passage of the 1990 crime bill, most white scientists knew that crack cocaine and cocaine were the same drug. Yet, I think the vast majority of the senior scientists remain silent while the discussions were going on in DC about criminalizing young people. So what ended up happening is that you have these young people end up in prison, and some of them were put in prison for long years for having just a little bit of crack cocaine on board. Those are the type of things I'm hoping that the new government will address. So where is NIDA in all of this? So we have the NIDA intramural program is located, as you know, in Baltimore. Baltimore City is one of the most segregated city in the country. So as you can see here, there are only a few spots where there's some degree of integration, but the segregated area of Baltimore's are vast, okay? After the quarantine, I mean, I live in a neighborhood that's really very segregated itself. During the quarantine, I started to do a lot of walking in the neighborhood, and I discovered all these areas that because I was never walking as much as I did last spring. And if I move 5 blocks one direction or 5 blocks in different direction, the people that I encountered walking were very different. If I went west from my house and I went 5 blocks, most of the people that I met were African Americans. And if I went east, and I could walk for hours going east, and I wouldn't see another Black person walking in my neighborhood. So it's just to show you, I mean, I moved into this neighborhood back in 1995, and it's remained segregated from that time. So now, in terms of NIDA intramural program, my conclusion is that participation rate of Black individuals in some of our clinical research could be better. So why is it, I mean, back in the 1990s and early 2000s, we always were having discussion about how to better recruit subjects from some of those communities. So the question is, can the NIDA IRP develop and implement strategies to significantly engage Black communities in Baltimore? So what I've concluded is that there are barriers to community engagements that come from the researcher and staff that come from the Black community, Black communities themselves. So in terms of researchers and staff resistance, I think personal biases that are conscious but deny might play a role, limited field and community-based experiences, so people don't want to engage a community they don't understand, and study design. The PIs don't see the need to interact with the Black communities, expecting that they would show up because they're getting paid to participate in the research. the failure to understand the various perspectives of individuals from Baltimore Black communities. And I think the researchers are doing research using a basketball paradigm to try to understand SUDs, while we should be using more of a soccer paradigm. It's very interesting from my perspective that scientists have real lack of understanding of the rationale for including Black individuals in research projects. You would think there would be much more aggressive in terms of doing it, given the racial inequities that I mentioned at the beginning of this section. So we need to do a better job to explain the need for cultural competence and sensitivity among our clinical researchers. We also need to introduce researchers to cross-cultural communication. So the other problem is who the messengers are who address the Black communities of Baltimore and elsewhere. Who are the people in the audiences that these messengers interact with? How do we model the messages that we're trying to send? I think from the time when I was doing clinical program, a lot of the people that I talked to were more interested in therapeutic approaches and prevention. They were not so much interested in what the causes were, while white investigators, including, and also me, I might be interested in the causes. Now, the resistance from the Black community may come from different vantage points. There's, as I mentioned to you before, we have a history of abusing Black Africans, Black Americans in the United States. And so there's mistrust. This is why we're having this issue with the vaccine. There's a mistrust of white institutions and researchers. There are people, when I first moved to Baltimore, there were a lot of people when I approached them to get engaged in our clinical program who told me the stories of Johns Hopkins and their treatment of Black Americans in Baltimore. I was totally flabbergasted at first, but then I remember that my alma mater wasn't innocent either. And there's economic constraints where people cannot really have access to transportation to come to our building. Should we do what the NIA, National Institute of Aging, did, go to where the people are? Health literacy, should we get more involved in teaching some of the people about the prevalence and incidence of SUD in some of these communities? And so the community in Baltimore, from my interaction with them, they are afraid of being exploited, and with good reasons. They're concerned that there might not be any benefits for them, with good reason, because I dare say that the benefits from the research that we've done in Baltimore have benefited the scientists like myself much more than it's benefited the people in Baltimore who need us. And they're afraid that if people start getting into the neighborhood, then that would draw attention from the police. So there's a number of benefits from engaging the Baltimore Black communities. That one of them is it would enhance training opportunities in the presentation clinical course in epidemiology of SOD for local students. There are several historically Black colleges in Baltimore. One of them is Morgan State, another is Coppin State. In the 1990s, we interacted a lot with Morgan State under other scientific directors. And then in the late 90s, those interactions were broken. Develop effective community-based method of recruiting and retaining Black participants in clinical research. One of the problems that we've had in the past is recruiting Black women from long-term assessment and treatment programs, if those included inpatient stay that were longer than a week or so. So we need to come up with ideas about how to address these issues. So in terms of general commentaries, the discussion of racial inequity, equity, and diversity are always very traumatic for some individuals. So this is Tom Sowell, who was a quite conservative person. He said, when people get used to preferential treatment, equal treatment seems like discrimination to them. And I think that's very true of scientists, including PhDs and physicians. So in terms of the audience, I would like you to reflect on this. How did you feel throughout these presentations of facts, not fiction, about the racist history of science and medicine in the US? Were you surprised about some of these facts? I know a lot of people don't pay attention to what has happened to the Black community. What changes would you like to see happen in research and practice with regard to substance use disorders? I'm focusing on substance use disorder because I'm assuming that most of the people listening to me are engaged in substance use disorder research. Or reflections. Why did it take the murder of Mr. Floyd, the virtual murder of George Floyd, for the NIH director to recognize the impact of racism on all aspects of health in the United States? Why did it take until the summer of 2020 for NIDA to suddenly want to try to positively impact the lives of Black professors, Black patients with SUDs, and to increase funding for postdoctoral fellows and other programs? Why did NIDA Happy Scientists never pursue any real tangible relationships with Black Baltimoreans after having existed in Baltimore for more than 40 years? So those are questions that I'd like people to try to answer, but there are ways that we can engage together to fight for racial justice. I think all of us should pledge to name racism when we see and hear it. We should not just talk about racial equity and not virtue signaling. We need actionable plans to address racism in our midst. We need to have raise funds for Black causes. Those of you who live in Baltimore, we have the Thurgood Marshall College Funds. They're always looking for more contribution or donation, so you could help with that, get some Black kids through college. You could join and participate in organizations that support anti-racism training. Have to facilitate workshop in your churches, synagogue, temples, workplace, and in your gyms. I guess you cannot go to gyms now, or you can challenge those individuals who claim that the lack of diversity and inclusion in science and medicine is due to problems with pipelines. I think this is like the biggest obfuscation that exists right now, the problem with pipelines. So the important points I would like people to remember is that racism not linear unscientific classification of race cause and continue to cause disparities in science, medicine, and SUD research and treatment. We need to be cognizant of the true history of American science and medicine and false claims of racial innocence by scientists and physicians. We need to make specific plans in order to dismantle racism in science and medicine, because it's not always about the science. I know a lot of people like say, why it's just about the science. It's not. Science is political. It's always political. Fight the virtue signaling that is too rampant everywhere in science and medicine. Let's not let people get away with just writing this supercilious statement about racism and then tomorrow do nothing about fighting. And finally, Black physicians matter. We should try to increase the numbers of Black physicians. Black scientists also matter. We need to train more PhDs to do research. And one of the statements that I learned recently from one of my friends is that diversity and equity activities done the right way are not necessarily the right way. So we need to engage with Black Americans, even when what they're saying might be uncomfortable, so that we can have better ideas of how to address the issue that impact the Black community. We need to, white scientists and physicians, to stop behaving like the great white saviors, because you don't know what hurt the Black communities in the US. I think the US can do better and must do better. And those of you who are interested in doing better should read the following two books. One is Stamped from the Beginning by Ibram X. Kendi, PhD. He's the author of How to Be an Anti-Racist. He's now the Andrew Mellon Professor in the Humanities at Boston University. And the ones that I really like, I just got that one. It's called Blaxortion, Karens, and Other Threats to Black Lives and Well-Being by Teresa Robinson. She's a professional anti-racism speaker and coach. I think one of these days, NIDA should really invite her to talk to us. So in conclusion, what I've tried to do is go through the history of the policies and economic set that are and the social hierarchy set up that have led to the poverty and inequity in housing, transportation, jobs, in education. And I've tried to discuss how these inequities have affected health outcomes, whether it is maternal increased prevalence of maternal mortality, chronic conditions such as kidney disease, hypertension, diabetes mellitus. So in order to change the outcome, we need to go at the sources and address the sources. So I'd like to conclude by stating I would like all of us to do no harm and with liberty and justice for all. Thanks for listening. Thank you.
So thank you, Jean. That was wonderful. Thank you very, very much. Does anyone have any questions for Dr. Cadet? You can put them in the chat or just start talking and let us know. Well, if there are no questions, thank you again, Jean. Thank you for everyone for attending. Thank you, Emily and Michelle Jobs for being here, part of the Racial Equity Initiative. And if you have any questions or need more information about that group, you can contact Michelle or Emily. Okay, thank you all very much.
Thank you.